Okay, so now we will read about the HIV, which on long term causes AIDS. So it has got two types, that is HIV 1 and HIV 2. Now first we have to see to which family this HIV belongs and what type of virus it is. So quickly tell it in your mind. So yes, this HIV belongs to retroviridae family and is a enveloped RNA virus and is a enveloped RNA virus belonging to retroviridae family. Okay, now this is a virus in which we have to read about the morphology in a little detail, because its morphology is helping it in its pathogenesis. So we have to know about the morphology of the virus, and sometimes this morphology is also asked in the university exams. So knowing about morphology is a good to go for us for the university exam. So here morphology can be described in 4 points. So first we'll see about the nucleic acid. So yes, it has two positive sense single stranded RNA. The HIV has single stranded RNA, and those single stranded RNA are positive sense RNAs. Okay, those are positive sense RNAs. Next is the capsid. Okay, so what does that positive sense means? The positive sense means those positive sense RNA can be directly reverse transcripted to DNA. But if it would have been the negative sense RNA, then it has to be first. It would have first converted to positive sense and then to uh, DNA. So that's the difference between the positive sense RNA and the negative sense RNA. That in positive sense RNA, it can be directly reverse transcripted to DNA, but in case of negative sense RNA, it has to be first converted to positive sense RNA and then to the DNA. So that is the difference between positive and negative sense RNA. Now coming to the capsid. So capsid is that all in cases of all the viruses, we have the nucleic acid, and surrounding that nucleic acid is a capsid which is made up of capsomeres. So this HIV also has capsid which is made by the P24 proteins. This P24 protein is very important for us. We will see it later in the diagnosis part. What is the importance of that? So capsid is made up of P24 proteins, and inside the capsid we have nucleic acid, and not only nucleic acid, we have some enzymes also which this virus possesses, which can be remembered by the mnemonic RIP, rest in peace. That we know that after the infection of the HIV, the person has to go in the rest in peace, maybe 10 years later or 20 years later or 5 years later, whatever may be the time, but has to be will be going to the RIP. So by that we can remember the enzymes in the virus. What are those enzymes? So R means reverse transcriptase enzyme, I means integrase, and P means protease. So these three enzymes are present in the virus inside the capsid, along with the positive sense single stranded RNA. Along with the positive sense single stranded RNA. Outside the capsid there is matrix, and that matrix is made up of the P17 protein. So note here that the capsid is made up of the P24 protein, while the matrix is made up of P17 protein. P17 protein. Okay. Now coming to the symmetry part of the virus. So symmetry of the virus is icosahedral symmetry. The symmetry of the virus is icosahedron symmetry. Envelope of the virus. So it is lipoproteinous in nature. Okay. The envelope is that it is lipoproteinous in nature. The lipid part is derived from the host cell, as the case in all other enveloped viruses. So here also the lipid part is derived from the host cell membrane, while the protein part is virus coded. Okay, so we have read it in the general virology as well. So protein part is virus coded always, and the lipid part is derived from the host cell membrane. And here the protein part is GP160. This should also be remembered, which is made up of two subunits. The which is made up of two subunits, GP41 and GP120. Mind that this adding these two 41 and 120 will be giving you 161, but that is not, this is not a simple addition. Okay, so that 41 plus 120 does not come out to be 160, rather this is does not come out to be 161, rather this is 160. Okay, so GP 160, glycoprotein 160 has two subunits, GP 41 and GP 120. These, both of these subunits help in the penetration of the virus, so these are also important and should be remembered. So we have seen P24 proteins in the capsid, P17 protein in the matrix, and GP 160 glycoprotein in the envelope. So these things should be remembered. This is all about the morphology of the virus and should be remembered for the university exams. Now coming to the mode of transmission of the virus. Generally, there is a view that the HIV most commonly transmitted by the sexual intercourse, but this is not so, and the most common mode of transmission of the virus is the blood transfusion. And whenever you will be writing the in the university exams about the mode of transmission of the HIV, you should write in this order. The order should not be changing. You should be writing in this order, that the first and the most common mode of transmission of the HIV is the, that is in case of 90% cases, the most common mode of transmission is the blood transfusion. The next common mode of transmission is the tissue and organ transplant. The next most common mode is the mother to child in case of 30% cases. Then needle stick injury is the next most common mode of transmission, and the sexual intercourse is the next common mode of transmission. So sexual intercourse, see here, occurs, the transmission via sexual intercourse occurs in less than 1% of cases. So that is not the most common mode of transmission. Rather, most common mode of transmission is the blood transfusion, is the blood transfusion, 90%. I'm repeating this, this is blood transfusion, not the sexual intercourse. So this should be, the mode of transmission should always be written in this order, that is blood transfusion, tissue and organ transplant, mother to child, needle stick injury, and the sexual intercourse. Okay, now coming to the pathogenesis. Now coming to the pathogenesis of the HIV. So HIV has glycoprotein in the envelope. We have talked about this in the morphology. That is called as GP120. The HIV binds via the GP120 to the CD4 receptors on the टारगेट सेल्स. तो GP120 के थ्रू वो CD4 रिसेप्टर्स के साथ बाइंड करता है ऑन द टारगेट सेल्स. टारगेट सेल्स यहाँ पे कौन से हैं? द टारगेट सेल्स आर द T cells. Okay. Now, when that HIV binds to the target cells via GP120, so through that GP120, this also binds to the co-receptors. Co-receptors are nothing but the chemokine receptors. Remember this, the co-receptors are the chemokine receptors. And what is the name of those co-receptors? That is CXCR4 and CCR5. The CXCR4 is present in the T lymphocytes and CXCR5 is present in the macrophages. Okay, so this would be always remember that the co-receptors are the chemokine receptors. And what are those chemokine receptors? Those are CXCR4 present on T lymphocytes and CCR5 on macrophages. So that means if the HIV is binding to the T lymphocytes, then the co-receptor will be CXCR4, and if it is binding to the macrophages, then the co-receptor will be CCR5. Okay. Now, after binding to the so after binding to the co-receptors and the CD4 receptors, this GP41 subunit, the GP41 subunit that the GP120 has, we know that GP120 has two subunits. GP120 has two subunits which are 41 plus, which are 41 plus 120. So this 41 subunits that we have, that facilitates the fusion of HIV to the target cell membrane. So till this stage only the virus has fused to the target cell, but now the GP41 subunit is causing the fusion of the envelope of the HIV to the target cell membrane, the cell membrane of that target cell. So once that fusion is completed, then the nucleocapsid of the virus enters inside the target cell, enters inside the target cell. Then that enters inside the target cell. Now, after entering in the target cell, so once the capsid enter inside the target cell, the capsid will be released, and capsid will be broken, and after breakage of the capsid, the reverse transcriptase, the integrase, the protease, and the RNA of the virus will be released in the cytoplasm. Now the functions of the enzymes begin. So now reverse transcriptase synthesizes the single-stranded DNA from the two single-stranded RNA strands, and after formation of the single-stranded RNA, I mean single-stranded DNA from the single-stranded RNA, so RNA DNA hybrid is formed. The newly formed DNA will make hybrid with the single-stranded RNA. Why? Because they are complementary to each other. So that's why they make RNA DNA hybrid there. And after the formation of the hybrid, the same enzyme reverse transcriptase degrades the RNA of that hybrid. So what remains there? Only the single stranded DNA. So as there is single stranded free DNA that replicates using the host cell mechanism to form double stranded DNA. So now it is using the host cell mechanism and host cell replication, and thereby it is producing double stranded DNA. That double stranded DNA enters inside the nucleus of the host cell, and that gets integrated by the enzyme of the virus, which is called as integrase enzyme. So the now that double stranded DNA is getting integrated into the human genome. And now with each cell division, with the each division of the host cell, the with each replication of the DNA in the host cell, the viral DNA will also get multiplied. So what will happen? As it multiplies inside the cell, the number of the genome of the virus will also increase, and thereby after that the biosynthesis of all the enzymes also occur, and then they release out, the virus is released out and then infects the other cells. So this all happens there, and after the biosynthesis stage, biosynthesis means synthesis of the viral DNA, and the enzymes like integrase, protease, reverse transcriptase, and the capsid proteins, these all are synthesized, and then the virus assembly occurs and they are released out. And once these viruses are released by the process of budding, then they infect other immune cells. Then they infect other immune cells, thereby over a time the immune cells number decreases. So this is all about the pathogenesis of the HIV virus. Now coming to the kinetics of immune response in HIV infection, means how does the immune system go along with the HIV virus over a long term. So to see that, See here, after the entry of the virus, there is transient high level of viremia. So in blood there is high level of viremia, and P24 protein that we have read is a capsid protein. Okay, so P24 protein is also released in the blood. So therefore there is P24 antigenemia and very high level of viremia as well. This P24 antigen is very helpful as it helps in early diagnosis of HIV. So after the entry of the virus, so there is high level of viremia and antigenemia, but immunoglobulins against the HIV antigens are not formed quickly. They take a time of about 3 to 12 weeks to form the immune immunoglobulins against those viral antigens like P24 protein and some other proteins of the virus as well. So this period in which the antibodies are absent or the antibodies has not been formed after the infection of the HIV is called as the window period. Sometimes this is asked in Viva exams as well, like what is the window period and how long is the window period. So it is 3 to 12 weeks. Okay, the window period is 3 to 12 weeks long, as the immunoglobulins are not formed quickly, and the immunoglobulins are formed only after a duration of 3 to 12 weeks after the infection with HIV. So that is called as window period and the duration is 3 to 12 weeks. Now coming to the next point, that antibody to P24 and the P55 antigens are the first to appear after the window period. So after the window period, the antibodies which appear first are the antibodies against the P24 and the P55 antigens. And among all the antigens, the most important antigen that is formed is the IgG antigen. This is the consistent and the long lasting antigen, and therefore whatever assays that we perform for the diagnosis of HIV, we usually uh, try to detect the IgG antibody. We try to detect the IgG antibody. So this is how the immune system is reacting to the or is responding to the HIV on a long term basis. So now we try to detect the IgG antibodies for the detection of the HIV antibody, for the diagnosis of HIV, and the antibodies first to appear after the window period are the P20 antibody against the P24 antigen and P55 antigen. So after long term, what happens that ultimately with the infection of the HIV, there occurs lymphopenia. There is decrease in the number of lymphocytes. There is T cells deficiency due to destruction of the T cells over a long term. There is inverted T4 T8 ratio. The ratio of T4 and T8 cells, number of T4 and T8 cells gets inverted. There is polyclonal activation of B cells that leads to formation of different immunoglobulins against different antigens. There is hyper gamma globulinemia. There is decreased cytotoxic response by C8 cells, which are the cytotoxic cells. So cytotoxic response is also reduced. This hyper gamma globulinemia is due to polyclonal activation of the B cells. Then there is altered function of monocytes. The function of the monocytes is also reduced. Now, as we have read that there is no antibodies in the window period, so how can we detect the HIV infection in the window period? For that, we know that the P24 antigen is the first to appear in the blood. So, however, uh, the antibodies are not there, but the antigen is still there. Okay, although the antibodies are not present in the window period, but the P24 antigen causes the first antigenemia, so that's why it is present in the blood, although the antibodies are not present. So in the for detection of the HIV in the window period, we have to be using this concept to detect the P24 antigen for the diagnosis of HIV. So if we are able to detect the P24 antigen in the window period, that may help in the diagnosis of HIV. So how can we detect the P24 antigen in the window period? For that we use the fourth generation ELISA kit and the RT-PCR. RT-PCR is simple, that will directly detect the gene of the virus, as there is viremia also in the window period. Okay, in the window period there is viremia also, and there is P24 antigenemia also. So for P4 antigenemia detection, we can use the fourth generation ELISA kit. For the viral RNA detection, we can use the RT-PCR method. So by these two methods, we can detect the HIV in the window period when there is no elevation in the antibodies against the virus. Now coming to the stages of HIV infection, sometimes this is asked as short notes in university exams, like what are the stages of HIV infection. So there are total 5 stages of HIV infection, and we will read it in points so as to remember it for a longer duration. So first stage is the acute HIV syndrome. Acute HIV syndrome is the first stage that appears after the infection for the first time. That is, in that case, the CD4 cells count is more than 500 per mmq. That is normal. The CD4 count remains normal in the first stage, that is acute HIV syndrome, in which there is just the viremia and P24 antigenemia. That occurs in case of acute HIV syndrome. So in that acute HIV, in the first stage, the HIV reaches to the lymphoid organs and multiply there, and that's why there occurs this primary viremia. That's why there occurs this primary viremia in the acute HIV syndrome, as there is to the lymphoid organs and multiply inside, there occurs primary viremia due to increase in the number of the virus, and just there is flu-like illness. Okay, next, after the first stage, there occurs a very long asymptomatic stage in which there is no symptom of the infection, and this is the stage where CMI and AMI comes into play. Due to the action of the CMI and AMI, this asymptomatic stage is seen, and depending on the CMI and HMI, this asymptomatic stage varies. If someone has very good CMI and HMI, the cell mediated and the humoral mediated immunity, then the asymptomatic stage will be for a longer duration. If someone has less CMI and HMI, then the asymptomatic stage will also be lasting for a shorter duration. So due to this immune system of the body, the viremia decreases, but the HIV persists in the lymph nodes. This should be noted that the HIV persists in the lymph nodes. The viremia decreases. In a normal person, in a healthy person, this asymptomatic stage lasts for about 10 years, because the body is able to control or suppress the virus for about 10 years until it is not increased in very much in number. So until its number increased very huge, a number becomes very huge, the body controls the virus or suppresses the viremia, tries to suppress it. So in that stage, the viremia will not be present. So the clinically there will be nothing. There will be no symptom or nothing will be there. But there is not, it is not the microbiological latency, it is just a stage of clinical latency, but not the microbiological latency. What does that mean? Microbiological latency means the virus is not absent from the body, it is present, it is present inside the lymph nodes, ये जस्ट वहाँ पे छुपा बैठा है lymph nodes में. ओके, बस हो ये रहा है कि क्लिनिकल सिम्टम्स नहीं आ रहे हैं, बाकी वायरस तो छुपा बैठा है lymph nodes में. So since it is not appearing in the blood, there is no viremia, there is no clinical symptoms, that's why there is, since there is no clinical symptoms, that's what is called as the clinical latency. And since it is not appearing in the blood, and you may think that the virus is not present in the blood, so that's why it is the microbiological latency, but it is present in the lymph nodes. The third stage, the third stage is the persistent generalized lymph adenopathy. How can we define this persistent generalized lymph adenopathy, or simply, or in simple words, how can we know that the patient is has reached to this third stage? That, for that we have to see the enlarged lymph nodes, how much enlargement, and at what sites the enlargement is, and for how long the enlargement to the lymph nodes is. So the enlarged lymph nodes, the enlargement should be more than more than 1 centimeter diameter, and the enlargement should be at more than two sides, and this should be persistent for more than 3 months. So if this all criteria meets, then we can say that the persistent generalized lymphadenopathy, that is the third stage, has reached. Okay, now what is the reason behind that lymph node enlargement? The reason is simply the multiplication of the virus inside the lymph nodes. So as the virus multiplies inside the lymph nodes, the size of the lymph node also increases. Next, the fourth stage is the symptomatic HIV infection, in which there is certain symptoms. And why does those symptoms appear? So those symptoms appear due to decline in the CD4 level, CD4 cells. We know that with the infection of the HIV, there is decline in the CD4 cell level. So as the CD4 cells decline, so that's why the chances of infections increases, and hence those opportunistic infection occur, which the symptoms of which are the diarrhea, weight loss. Weight loss should be more than 10%. Okay, the weight loss is of more than 10%, the fever for more than 1 month, and other opportunistic infections. So these all symptoms are present in the symptomatic HIV infection. Okay, now the fifth stage, the fifth and the final stage is the AIDS proper. That means uh, the stage in which the AIDS manifest, that is the end stage of the HIV infection, and the CD4 cell count in this stage becomes less than even 200 per mmq. Okay, the CD4 cell count in this AIDS is less than 200 per mmq. The viral load is very high. There is opportunistic infections, there is neoplasia due to certain viruses occurs. Okay, and opportunistic infection by some microorganisms occurs. We will see about those microorganisms which can cause these opportunistic infections in the HIV infection. So that, and other than that, the HIV may also cause the encephalopathy. So these are some of the features that we see in the AIDS stage, which is the acquired immunodeficiency syndrome. That means the final stage has reached, and in that stage, these symptoms are seen. Now coming to the opportunistic infections. So these opportunistic infections are sometimes asked in the exams of the university, in the theory exams, and are very important as well to know about the opportunistic infections in HIV. So We will see the opportunistic infections according to the type of organism, and like bacteria, viral, parasitic, and fungal. So the bacteria which are causing the opportunistic infections most commonly are the Mycobacterium tuberculosis, which is causing TB, the Salmonella, which is causing typhoid, and Listeria, which may cause meningitis. So these are some of the bacteria which commonly cause the opportunistic infections during HIV infection. The viral agents which may cause opportunistic infections are the CMV, herpes, and Epstein-Barr virus. The fungi which may cause the opportunistic infections are the Candida, Pneumocystis jirovecii, Aspergillosis, Mucormycosis. And the parasites which may cause these opportunistic infections are the Toxoplasma gondii, Cryptosporidium parvum, and Cryptosporidium hominis, Cystoisospora bailey, and Cyclospora cayatinensis. These these names should must be remembered because these are asked in the viva as well as in the university exams. So these opportunistic infections should be at the tips. So this is all about the first part of the HIV. Now we'll see the lab diagnosis in the next part. Okay.